look like it. So yeah, thank you for making time on your Saturday morning to be here. Yeah, it feels like we're living in very different times than the last coffee conversation, which was 4 weeks ago. That was May 23rd, and 2 days later, George Floyd was brutally murdered in Minneapolis. And of course, as everybody knows, that unleashed widespread condemnation and criticism across the country. And it feels to me like we may have finally reached a tipping point where a critical mass of people are angered and motivated to speak up against racism and police brutality and take action. But in the meantime, the COVID-19 pandemic still goes on, and many areas are seeing new surges of cases as their communities reopen and restrictions relax. COVID-19 has disproportionately hit people of color, including Blacks, Pacific Islanders, and Native Americans, but none harder than the Latino population, which make up 43% of the positive cases in Washington state, while only making up 13% of the total population. So to address these inequities rooted in racism, today we have two very special guests, Dr. Julian Perez and Mr. Edwin Lindo. Julian is a family physician at CMAR Community Health Center in Seattle. And Edwin is actually an attorney on faculty at the University of Washington Department of Family Medicine, whose work focuses on addressing issues of racial and social inequities in medicine. In addition to being a scholar, he is a community organizer, and he and his wife, Dr. Estelle Williams, who's a surgeon at University of Washington, organized the Healthcare Workers for Justice March, which took place in Seattle 2 weeks ago, and which drew, I think, an estimated 7,000 participants. Just so you know, we did try to get a speaker from Yakima to join us today, because Yakima has been hit particularly hard by COVID, but I think because of that, and especially this week that they have seen their hospital numbers overwhelm staffing capacity, we were unable to confirm a Yakima speaker. So sorry about that. One caveat, this hour-long conversation obviously isn't nearly enough to do justice to addressing anti-racism. At the WAFP, we do plan to host a separate town hall meeting sometime in the next few weeks, as well as send out a short member survey gathering some initial perspectives. So be on the lookout for those. And also, so you know, the board has prioritized anti-racism efforts in the near and longer term future. So yeah, please stay tuned for that. So with no further ado, I will turn it over to Dr. Perez.
Thank you, Julian. Good morning, everybody. Sound check, can you hear me all right?
Yes.
If you can hear me, just raise your hand. Great, all right. Well, it's a real honor to be here speaking with so many colleagues. I saw a few names that I've read about for 20 years as a family physician way back in medical school. So I want to start today by discussing just one major concept that we all need to continue to remember, and that is the issue of social determinants of health. We do actually quite little within our four walls of our clinics to help people live longer, better, happier lives. And that is a humble thing that I had to come to terms with when I started my practice, seeing people come in with diabetes and giving them pills that they couldn't afford, and then giving them free medicine that only lasted a month, and then having them try to read bottles that they couldn't read because they were in English, not Spanish, and then realizing they couldn't even read Spanish because they can't read and write. So I just want to share one slide with you as a bird's eye, and I will see if our coordinators can let me do that. The entire thing. And essentially, it's a slide from Wilkinson and Pickett, who do research in Great Britain, and they took a look at several factors, social factors, that really they make a formula of how well people will live within a given population. And so it's broken down by country, and what we see is that the relationship between the wealth disparity and the lives lived is very, very linear, and it's an impressive slide. If we can just get that on.
You should have the ability to share, but if you want to send it to one of us for us to share, we'd be happy to do that as well.
Okay. I see the entire screen, but it doesn't give me the ability to share, unfortunately. So maybe we'll
Look
come
down
back.
on your Zoom box. Do you see a little green button that says share screen?
Yeah, that's where I'm at.
Oh, okay.
It doesn't want to let me do that though.
Oh.
Okay, well, we'll skip it until we can troubleshoot that. Anyway, so one of the things that they include in this formula is trust. And this is something that has been very obvious to me in this pandemic of COVID-19, is that the people who are suffering the most, the people who are disproportionately infected the most and have the fewest resources are also the ones that just don't trust anybody. But you see this as well in our own populations of American citizens, people in the rural area. You know, there's a huge rural-urban divide in our country. We have political separation that we've never seen to this level ever, to the point where we have people that are able to walk up to the steps of their state capitals armed to the teeth with automatic weapons and assault gear on, and they're not kicked off the front steps. I mean, there's all kinds of very strange things going on in this country because of these huge divides, which trust and mistrust of government, of policymakers, of decision makers has really come to a head. And so that's something that's part of that formula that Wilkinson and Pickett came up with that has really stuck out in my mind. So as Lillian said, in the state of Washington, you know, Latinos make up 13% of the population, yet we're 43% or so of the positive cases. Nationally, we're 18% of the population of the United States of America, and we're around 27% of the cases. And what you see is that as this pandemic moves on, initially our Latino population was quite low in the number of people that were positive, and perhaps that was because not many were getting tested. But we see that the outbreaks happen in the big cities, probably where airplanes were flying in from international trips, mostly business trips and things like this. And then folks ended up going and seeing friends and family at the nursing homes, and that's where we had these huge explosions of mortality. That is obviously one group of people who has certain privileges and levels of education that are able to make those types of, you know, international trips, do business and come home, which led to the spread of this worldwide. That's the globalization phenomenon that we have, which is a double-edged sword, obviously. There's a lot of good things about globalization and a lot of things that are not so great. So this one allowed this thing to spread incredibly quickly and end up right in our front yards. Trying to think of where I was going with that. Anyway, we've got this disparity now that we've seen. I remember where I was going with that. In the white English-speaking American population, that was going like this, okay? And the Latino population was actually a small percentage of that. And what we see now is that is plateauing off now and actually starting to go down. Our number of cases are going down in our American citizen, English-speaking employed population. And what we see now is that small level of Latino cases is now starting to go up, and there's no end in sight. It just keeps on going up, 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 up. And so this is where you start to see the social determinants come in. People who are able to stay home because they're paid to stay home, they can get unemployment, Social Security, different programs to make sure that they have income to pay their rent. You know, they can stay home. Literally, we're paying them to stay home as a public health intervention. And our immigrant population, they don't have that. Perhaps before the current federal administration, perhaps they may have been able to stay home to some extent more because they would be able to get financial aid. But right now, very difficult for them to get financial aid to stay home. We have folks that are in what are known as the critical infrastructure jobs. I never would have thought that slaughtering cows and making meat would have been considered critical infrastructure, but that's probably just because I've lived in Seattle for 20 years. When I lived in Idaho, meat, you know, if you didn't eat meat, you were a communist. So yeah, it's critical to a lot of people. This is a huge part of their lives and a huge part of their diets. And right now, meat prices are through the roof because we've had so many outbreaks. So you see the outbreaks happen initially in those American citizen, English-speaking populations that went to the nursing homes, where you will almost never see this in the Latino community, where Latinos are putting their moms and dads in nursing homes. It just doesn't happen. But where the Latinos live and work, now you're starting to see these things come out. They don't have necessarily the work protections. They don't have necessarily unions that protect them in their workplaces, that guarantee them PPE, paid time off, sick leave, the ability to actually claim like, I'm sick and I got to get out of here for my wellness and for your wellness. I need to get out of here. Oftentimes, my patients will just say, if I don't show up to work, I'm gone, and they'll find someone to fill my spot. And so they're very sensitive to being able to, come into appointments and making sure that they can get everything done possible on the day that they see you. And this all has to do with, what they have and what they don't. And those benefits that we enjoy so much and take for granted often as US citizens, our patients that are immigrants, even the ones that are legally documented green card holders, slowly but surely they've been pulled out of that path of opportunity, trying to become integrated as people of this country's US citizens. And no more obvious is that fact than in the public charge changes that have been made at the federal level. The public charge definition is somebody who essentially is dependent of the state and owes the state money. There were certain benefits, financial benefits and financial aid that were always under that. But under the Trump administrations, those have been amplified and blown up to many other things. And so a lot of our patients just say, well, I want to be a citizen someday. Hey, that's a good thing. These are people that are here, working, have a family, follow the rules, don't break the law, and want to be US citizens. That's a good thing. That's America. That's what we should be about. And they are actively being, disincentivized to take care of themselves and take care of their families, because this public charge rule has been, there's so much disinformation, to be honest, about this public charge rule that people can't even tell like what counts against them or not. And so there's a lot of education that we're having to do with food assistance, EBT, for example, that does not count against that. The King County Public Health and state of Washington is making a big push to all the people in the state saying, this is something that if you need food, it's not going to count against you. Please apply. We need to get you some help if you need the help. And so things like this, those structural institutions, those structural ways that you can discriminate against people and have it be technically legal, These are the things that our communities and the immigrant population and the Latino population have fought against for years and years. And it's very aggressive against us at this point. So the interesting thing about this pandemia of COVID-19 is that you have pandemic COVID-19 that's now on top of this historic pandemia of 500 years of racism that has touched this continent. And then you have another pandemia, which is mistrust. And so if you have a situation where people in authority are telling you, please stay home, keep distance from one another, cover your mouth and nose. But that same authority, it doesn't matter if it's King County Public Health or if it's the United States government, NIH and CDC, it doesn't matter. In the eyes of people who are struggling and constantly trying to defend themselves against the system, they don't trust. They don't trust what they hear. And so is it any wonder that people in Yakima are not wearing masks? They're not social distancing. They continue to want to see their families. They go to graduation last weekend, and I have cardiology friends that worked in the community for 8 years that were there, and they said nobody's wearing masks, nobody's distancing. It's like nothing's happening in this country. And so I am very concerned that distrust, that inherent distrust of the system that has been trying to keep people out of this country, continuing to make their lives miserable, that's hurting them and their families, is a huge part of what's going on here. And so a couple things that I've done personally, there was a case that came by my email one day by the leader of the Seattle Public Schools. And she said, look, there's a family who, they're all sick at home and they don't know what to do. They don't know where to go. They heard about these hotels where you can get isolation, and they just don't know what to do. And essentially out of that conversation came the fact that they don't know who to trust. They don't know who to go to. And so we said, look, there's a need for some kind of a clearinghouse or a coordination of people who have the trust of the community. And so what we did is we formed a Zoom group in Spanish, and invited anybody who wants to join to talk about issues. And we call that Zoom visit Confianza y en Comunidad. Confianza means confidence, in trust. En comunidad, in community. So those are two words in Spanish in the Latino community. If you say confianza y comunidad, people are like, okay, I'm going to listen to you because you're actually using the lingo that I know, and that's the lingo that I trust. And so we get about 35 to 40 people every week on this call, which doesn't sound like a lot. But what we did is we have targeted very specifically people who have the confidence of their local communities. And one example is a woman who runs a music program. She does symphony. She's actually a musical director. She's bilingual English and Spanish. and she has a live Facebook page where she has her symphony every week. She said, look, I get 25 to 3,500 viewers. Okay, that's amplification, and that's what we need. We need someone who's got the trust and admiration of 25 to 3,500 people that speak Spanish and cares about this situation. So she said, can you make some kind of a COVID message for me that I can put on the beginning of that? I said, yeah, I can definitely do that. And so I've sent her 2 or 3 messages about wearing masks and about social distancing. We have, within the Zoom Spanish Confianza en Comunidad group, we have come up with commercials in various languages: English, Spanish, Purépecha, Mixteco, the languages, the indigenous languages that some of our Spanish patients speak, so that we can give them the information that they need by somebody they trust in their language. And we are hoping that we can get people to buy into this. A, that the disease is real, because there's a lot of people that don't think it's real. B, that these methods are tried and true and they work and we have proof. And C, that all of the stuff they hear out of WhatsApp and Facebook and internet, that if you put a mask over your mouth and nose, you're gonna suffocate and die. Like, we have to dispel these myths constantly. It is the work of organizers. It is the work in the community, and it is the work in confianza that we feel like it's gonna make a difference. And at least at CMAR, we watch our numbers daily, very carefully. And we have had constant variations in the positive rate and some spikes where we've had to do mass testing. But in the last 2 weeks, it went, in the last 2 weeks, it's here and it's stable. And that is despite the marches, despite the outbreak in Yakima, despite the Memorial Day weekend. We think we're having an effect. The other thing that we're doing now is that we know you have to know who your audience is. And we know a lot of our Latino community, they don't, they watch Univision. So we have commercials on Univision. They listen to the radio a lot because a lot of our people are working all day and they can't have their phone or their TV. So what do? They grab the radio, turn it on, put it on the desk. There you go, they're working. So listen to the radio all day long. Now, CMAR knew that people listen to the radio. And so we started giving radio messages maybe 20 years ago. We would rent space. We'd rent time on 1360 AM and other radio stations. And eventually, what we realized was, this is really expensive. What if we just bought the radio station? And not everybody can do that. You know, CMAR has gone from a 1-clinic operation, now 45 years later. I mean, it's a huge organization. And there's been really smart people running this thing for a long time, and we're a federally qualified health center. So we were able to purchase that radio station. We now own and operate this radio station, and it's run out of our Museum and Cultural Center near the community of South Park in Seattle. And so we can decide whatever content we want to put on that thing, and it's all in Spanish. So we are in our clinics now with all the screens on the front. We put the logo of 1360 AM along with the logo of coronavirus, and we say, listen for updates. Escuchen para información en confianza. And so I'm on the radio every day at 12:15 giving quick updates on morbidity, mortality worldwide, USA, Washington State. I tell them about, you know, they'll say 3 people called in and they have these questions. So we do Q&A every single day. And on Wednesdays, we do from 11 AM to noon, a 1-hour show where we discuss a topic. And I got concerned that people were getting sick and tired of listening to me. And so I started inviting guests. We've had State Senator Rebecca Saldana come talk about the intersection between law and constitutional rights and COVID-19 pandemic. We have had King County Public Health Dr. Matias Valenzuela come and do an overview of the pandemic and the best practices, especially with respect to people needing to work, how they stay safe at work, when to call in sick, and what to do when you are ill. And we've had most recently Dr. Oscar Bailon, who's a cardiologist that worked in Yakima for 8 years. He now works at the UW, and he knows Yakima backwards and forwards. And so he came and talked about what's going on in Yakima. And when he told us what happened, he said there was a hospital that just closed. There's only one hospital, and I knew immediately 1 in 4 people that are tested in Yakima are positive. They just had a high school graduation, and 1 hospital's closed. It was very predictable that their last remaining hospital is overrun. Very predictable. So that's some of the things that we're doing. We take it at an angle of human rights and trust at this point, rebuilding trust. And then, you know, now we have this horrible murder of an innocent man in Minneapolis. And our community is now having to figure out, where do we fit in the solidarity with Black America? And how do we integrate what we're trying to do for our health, along with the health of African American people, not become lost in that conversation, but also be part of that solution. So I'm going to pass it over to Edwin, who is going to tell you a little about the work that he's been doing for many years. And then maybe at the end, we can kind of talk a little bit about how these two communities are working together to beat this coronavirus pandemic. Thank you.
Thank you, Julian. Do you want to take questions? Because I think you provided a lot for folks.
We can take questions now, or we can do it afterwards. I have a feeling that when you talk, we'll probably answer a lot more of those questions too. Maybe do it at the end.
Okay, great. So first want to acknowledge the land on which we stand and give this presentation even virtually of the Coast Salish Duwamish people. I do my best every time we give a talk to acknowledge that, mostly because it's not given the weight that it's due. And land acknowledgement is great, but there's also opportunities for people to support the Duwamish people. They're not a federally recognized tribe in this country, even though they are the first people here. And so I think doing some homework on that. There's also this amazing organization that supports the Duwamish people called Rent Duwamish, where you can financially support them. I also want to acknowledge that yesterday was Juneteenth. Juneteenth is a holiday that many people may not have been aware of, but a holiday which was the emancipation of slaves. Unfortunately, it was 2 years after Abraham Lincoln declared the Emancipation Proclamation, which means that there was a cohort of white slave owners that even after it was declared nationally that slaves were free, that they held on to slavery in Texas. And it took until June 19th of 1856 to actually abolish slavery. And we can get into a whole conversation of what that means. But it's at the core of what I'd like to talk about. As mentioned by Dr. Perez, we are dealing with a multitude of pandemics. And some people don't like to suggest that racism is a pandemic or police violence is a pandemic, but I'd make the argument that it is. If we looked at the technical definition of it, it truly is situated within that definition. And I just got off a really important conference. It was an international conference of medical examiners across the world, 330 medical examiners, and they asked me to speak about the human rights issues of police violence. And I will situate it in the arms of COVID-19 and what that means, but when we have a full picture of what's going on, we can better understand it. Because what's happening is you have an individual like George Floyd, who was killed in broad daylight, captured on camera, who we found out later through the autopsy that he was a survivor of COVID-19. And in surviving COVID-19, which that in and of itself is quite the miracle, is then killed by the pandemic of racism. And he couldn't win that one. And that's the sad part that we have to deal with and sit in. I want to share a bit about what I shared with these medical examiners. It's a statement that many people can't comfortably sit with, because it is a bold statement. And the statement is that what is occurring to Black folks in this country at the hands of state-sanctioned violence is actually in direct violation of the UN Convention of Human Rights, and that it actually falls into the category of genocide. If we are to look at the definition of genocide, and I'm not trying to be hyperbolic or inflammatory, but as a lawyer, when we look at the elements of what constructs genocide, you're talking about definitions that say that a person, that a system or a country in whole or in part has an intent to destroy by means of killing members of the group or causing serious bodily or mental harm to the members of the group. and deliberately inflicting on the group conditions of life calculated to bring about its physical destruction in whole or in part. This definition was created because of the Holocaust. And there are very few times that it's been implemented. You can think of Darfur, you can think of other foreign experiences that have occurred that have implicated genocide. I want us to really sit with the reality that it could very well be the case that in these United States in which we currently sit, we are in the manifestation of genocide. And some say, well, how is that possible, Edwin? Like, it's not that bad. From 2013 to 2019, 1,700 Black folks were killed at the hands of police. 1,700. In 1951, there was a petition to the UN, Human Rights Convening, declaring genocide in light of the definition. And the UN Convention said, no, we're not listening to that. And Eleanor Roosevelt, who was the first lady at the time, felt the pressure to at least listen to the petition and sat there. And when asked, what do you think of this evidence leading up to a discussion of genocide? She says, I don't think they're wrong. And William Patterson, who was the petitioner, laid out 152 deaths by lynching and police violence. Just 152, and it still arguably met the requirement. Within the same span between 47 and 51, which was the data he pulled, that those 6 years, that 1,000 or that 1,700 Black folks that were killed by police that I mentioned is also just a 6-year period. He was then, when he returned back to the United States, William Patterson had his passport revoked. He was blacklisted from receiving any work or jobs because he brought this to the international stage. Let's say it's not genocide, because that is a strong word. It is definitely and most clearly the United States creating refugees within its own borders. Because under the UN Convention, a refugee is defined as someone who is unable or unwilling to return to their country of origin owing to a well-founded fear of being persecuted for reason of race, religion, nationality, members of a particular social group, or political opinion. Now, you can't have refugees, technically, and this is the fascinating thing of law, you can't have refugees in your own borders. Refugees are people who are fleeing from the persecution. But if we were to look at the EU, it says that they would accept refugees if there's grounds of racial persecution of a population. And these human rights abuses or other serious harm, often but not always, are proven with a systemic or repetitive element. If we look at Canada, it says that they would accept refugees, even if the claimant is suggesting that they are a soft target for persecution at the hands of police racism against that claimant's group. So by definition, Black folks in this country, and I would argue Indigenous folks as well, could go to the Canadian border and demand asylum for the racial persecution that they're experiencing. That's big and scary, and it hurts that we're living in that country. And we, as healthcare professionals, I would argue, and why 10,000 people showed up 2 weeks ago to the protest, is because we know that it's wrong. We haven't necessarily pathologized it in the way that I think we should, though. We have pathologized it as, oh, that's an issue outside of the clinic. And I would make the argument that if we are actually family medicine providers that care for the community of our patients, because we know that when we care for the patient and they're healthy, they can go into their communities and make their communities healthier, that we are caring for the whole community. That means it doesn't stop within the borders of our clinic. It means that we do actually have to do what is right outside of the clinic and demanding justice to better the health of our patients. It isn't just police violence either. Dr. David Williams, who is an expert public health professor at Harvard, shares with us that 30,000 Black folks every year die of premature chronic illness that is due to the results of racism. And again, I'm speaking of Black folks because I want to focus that conversation considering that we're in the middle of the largest civil rights movement in the history of the world. And without a context of what that means, sometimes it could be lost on us. So how does it relate to COVID? And so with COVID, what we're seeing is not just in Black community, but indigenous communities here in Washington, the Latino community, is that living in conditions that were perpetuated by social political apparatuses or systems like legislation, policies, that it's no accident that we see the mortality and transmission rates that we see now. We'll take Seattle, for example, and I apologize for those who are outside of Seattle that it seems Seattle focused, but if we look at the highest respiratory rates, the highest respiratory disease rates in King County, it's in the south end of King County. It's near Georgetown, White Center. We're talking about asthma and other respiratory diseases. COVID has shown us that if you have a respiratory disease, you are more likely to face mortality because it will affect the pulmonary functions. And some people say, well, that's terrible and it's awful, Edwin, and we should do something better in the clinic. As a critical race scholar, and what I try to teach our students and my fellow colleagues is that actually when we know the history, we can actually get to the roots of why this exists. And the history is that not just in Seattle, but in many cities around the country, it is no accident that the highest levels of respiratory disease are in the most diverse and the most impoverished communities in the country. I'll take San Francisco, for example. I grew up in San Francisco, go across the bay in Oakland, and there's two freeways. There's 580 that's up north in the mountains of Oakland, and there's 880 that's on what they call the flatlands near the port where they drop off a lot of the cargo. The 580 mountainous, beautiful, incredibly expensive neighborhood, they have prohibited 16-wheelers from driving on that freeway. So the only freeway that the big wheelers can drive on is on 880. 880 drives directly through East Oakland. East Oakland has the highest concentration of Black folks in a zip code throughout the country. It also has the highest levels of asthma throughout the Bay Area. And as you can imagine, if you overlay the statistics of COVID transmission and mortality, they are also they are receiving the highest rates of those as well. But that wasn't an accident. There were wealthy white folks in the northern part of Oakland that said, you're not going to drive a big rig through my neighborhood. You can go through that poor neighborhood, but you're not doing it in mind. We go to Georgetown or White Center. At Georgetown, you see the big rigs going into the industrial area and the particulates dropping, flying out. They're getting into the backyards where our children play, and they play with the dirt and they play with each other. It may be rubbed on their face. It's not an accident that's where it is. Big rigs aren't driving through Queen Anne. And that's also not an accident. Queen Anne does not have a very high rate of respiratory disease, but it was a deliberate policy, legislative change and intent when those roads, those areas, and those neighborhoods were created. And some people say, well, Edwin, my job really isn't to be an advocate. Like, that's not what I do. I am a family doc. I care for my patients that walk through the door. And I would encourage us to say that, are we actually doing a service to our patients if when they come with asthma and we give them the inhaler and say, great, I'm taking care of this for you, but we're sending them back into the same environment that caused them to have asthma in the first place? I actually think, and many of you may already know, but I will let you know as someone who's not a physician, that the immense level of power that you have with that white coat that should be heard in the halls of legislative chambers, telling folks with the decision-making power that as a provider, I can't stand for my patients to be harmed by things that are outside of my clinic. And so now my job is to step out of the clinic to make sure that their environment is safe because it's my duty. Some people say, well, Edwin, medicine is not political. And I would have, my rebuttal is, I wish it weren't. But since day one of medicine, medicine has made itself political. Medicine is the reason why we see the form of racism that we see today. You say, well, what do you mean, Edwin? You have Johann Blumenbach, who was a physician in 1857, who wrote a book outlining the taxonomy of race and suggested that Black people were savages, Native Americans were governed by customs and did not wear clothes, and the only intelligent body that could possibly exist on this continent, or sorry, in this world, were Caucasians. I was a doctor. In 2012, there was a published piece by psychologists who were working with physicians that attempted to prove their hypothesis that darker skinned people were more aggressive and more sexually active and had a lower IQ because that's what they tend to find in animals with darker pigmentation. And it was published in a peer-reviewed journal. This is what is sitting in the annals of our institutions, and we can't run from it. What I hope I can encourage you to do is critique it and interrogate it so much that we can call it out and say, you know, I'm not going to stand for this anymore. And I'm going to put my foot down, and we're going to find a way to fundamentally change how medicine operates. So that's my brief talk. I really appreciate y'all having us and listening. It's an unbelievable time, both for the distress and the harm that's been caused, but also just seeing how many folks have stepped up to want to make a change, to me, is inspiring. So thank you.
Thank you, Edwin and Julian. Thank you very much for sharing your insights and your perspectives. And yeah, a lot going on. I agree, a lot is encouraging, and yet we still have lots and lots of work to do. So I want to open it up for questions. We do have the chat box, and my counterpart, Dr. Russ Meyer, immediate past president of the WAFP, will moderate that. And so please feel free to ask questions of either of them. I'd like to start off by asking one question to both of you. And I'm really impressed with the work that you've done at Seymour, Julian. Now, do you have advice that you can give to physicians who are not people of color, or who are not necessarily part of the communities that are most affected, in terms of how to establish community connections, or where to take those initial steps, because we don't have necessarily the advantages of being part of the community?
So yeah, that's a fantastic question. So Spanish, I've found, if you can speak whatever population you care for, if you can speak their language, or if you at least go to every effort to make sure that your interactions with them are interpreted in a way that they can understand, that is super duper important. We fought, really hard 20 years ago to make sure that all hospitalized patients would have interpreters, and it would be paid for through insurance and or through the charity funds of the hospital that are part of their not-for-profit mandate. They have to have a community benefit. And so a huge portion of that went to making sure that every non-English speaking patient had interpreters. Beyond that, getting into the community. I think the number one thing I can recommend is your job begins in the clinic, but it must be outside the clinic. And that can be virtually by radio, TV, op-eds in the newspaper. It can be physically volunteering at health fairs, or going to Latino League soccer games on the weekends and offering to cover sidelines for injuries. I mean, just get yourself out there. And the more they see you, and the more they recognize that you're a physician and you're showing up, that is huge. FaceTime cannot be matched. And FaceTime, can also be radio time. It can be volunteer time, but you must get outside of your clinic and show the community that you're there and you care.
Yeah, there's not much to add. I was going to say similarly, to just show up in a way that isn't even in the capacity as a physician. I think showing up as a community member and letting the community know, I'm here because I see you all as my community, and I want to be part of yours. And when you ever need the skill that I have, I'm happy to bring it along. Let me know when that is. But I'm actually here just to enjoy community and to be in your presence. That, as Dr. Julian mentioned, that goes a long way, because we are talking about, as he also mentioned, a pandemic of mistrust that is created by a legacy of a number of different incidents that leads to that mistrust. So it may start by humanizing the relationship outside of the clinic. And that could be then brought into the clinic when you're interacting with your patients.
Another thing I would say is that, you know, when I first got on the radio, I was not sure that I was going to be able to do this because I was nervous. I was so nervous, and my Spanish wasn't perfect, believe it or not. Like, I grew up in Spanish in the home, but man, I was not a good Spanish speaker until I went and spent 6 months in Mexico studying. And I was really nervous. And you know what they told me? They said, look, the people will remember the conversations the best of people that don't speak fluent Spanish, because they're like, do you remember that guy that couldn't speak Spanish? Yeah, I remember him. Oh, but do you remember what he talked about? Oh, yeah, I remember what he talked about. And they just give you that confidence, you know? I mean, they're on the radio all the time. It's just, for them, it's just like, it's what they do. But for us, it's super scary. Don't be scared, guys. Get on the radio. Start in English. Just get used to putting yourself out there. And people love to hear from doctors. I could not believe the value. I keep asking them, do you think they really care about hearing what I have to say? And always they say, absolutely. We have dozens of calls every day asking, please ask Dr. Perez this question. What's going on with this? I have a story. How can I get my family member taken care of? They care about access to doctors in non-traditional ways, for sure.
So Hilda would like to say something. So Hilda, if you could just unmute yourself, and then we'll get to Ray's and Debbie's questions.
So I'm also at CMAR, but I'm at the north end. I'm in Everett. So we've been seeing a pretty similar population that Julian deals with in South Park. But I know that, you know, we've been talking about COVID and just the rates of COVID infections in the Latino population. But I also wanted to touch on and see if anybody else has had a similar experience with your Latino patients. Our patient population, for the majority, are uninsured and don't qualify to get financial assistance from the government. And what I've been seeing is not just the effect that COVID has as far as infections is concerned, but also the economic impact it's had in our patients and the fact that it's affecting their other healthcare issues. So for example, I mean, I've had patients who are now, you know, we're how many months into this, 4 months into the COVID infection, and they have run out of their 3-month supply for their diabetic or hypertensive medications and are coming back to see me now out of control because they have not been able to purchase their medications, have not been able to eat healthy, have had to give up their housing because they can't pay rent, are not able to even come to the clinic because they have had to give up their car, or, you know, just don't have a way of getting into clinic. And I wonder if anybody, or, you know, has been evaluating this or has been seeing some of those same issues with other patients.
Yeah, I work at a Health Point down in Auburn, and so again, a very high Latino population, and I just see the exact same thing. And it's not just the Latino population; it's the entire population, and it even includes those that are insured, because a lot of people who are insured have high copays, and I have people that don't want to make even virtual visits because you know, they're afraid that they're going to get charged. And so, yes, I agree that it's a very widespread problem, and it doesn't just encompass the undocumented or uninsured population.
So Edwin and Julio, we have a question from Ray about how do physicians get involved and get our health systems to affect change from personal interactions in the office to the larger world of our local community and state. So Edwin and Julian, how might you respond to that?
I think the crux of that question is, how can I make sure that my organization supports me in this? Is that essentially what's being asked?
I'm going to interpret Ray here. I think it's both ends. There's a piece of how do you at work affect change, and how do you out in your personal life in the community affect change in that greater world of the city, state, federal government.
Right. Okay. So this is a whole talk in and of itself, but I think the key is to ask different questions. That's what I would say. I had a student follow me in clinic, and she said, Dr. Perez, you don't spend any more time in the clinic in the rooms with the patients, but you just ask different questions. I said, give me an example. She said, you're not afraid to ask them about if they're employed, if they can read and write, if they have food insecurity, if they're undocumented. You're okay asking them those questions. And in that room, I think we all will agree that that is a sacred space. People come to the doctor because they trust that this will be, and you can always tell them again, like, this is confidential, this doesn't leave the room. But knowing those things is really important to figuring out how do I best how do I best serve this patient? And so ask different questions, whatever questions you feel like would be most beneficial. But those are the 5 that I ask a lot. On a broader scale, you look at your mission, vision, and values of your organization. And if you can convince your leadership and your funders that your mission, vision, and values need to include social determinants of health, addressing inequalities, addressing systemic racism. If you can get that language into your mission, vision, values, they are obligated to give you the time and the funding to do that as part of your FTE. And then I'm curious to see what Edwin has to say.
Yeah, I mean, the truth is, and Julian knows this, for much of our careers, we do this work knowing it was never going to get supported. And we did it anyways because it was absolutely what we had to do it. And actually, for those who would like to do it, but they haven't had the chance, I got to tell you, what it also does, it fills you. It gives you the food to continue this work when you're in the community, when you're providing in ways that may be atypical to what a primary doc would do. But I agree, it's also creating processes and policies that when you do things, you can say, but this is our mission, right? You told me this is our mission. I'm just fulfilling the mission of the organization when I go out and speak at a city council, when I go to the soccer game with the community and I serve as the team medic, and all I'm doing is, providing them water and support. But it's finding ways that we move into culture, and culture allows us to build relationship and out of, unfortunately, the processes of medicine, because that removes us from the relationships and from the cultures. Because before you can go do that, we need to have a committee meeting on whether Julian can go sit with the students at the soccer game. Do we really need to do that? I don't think so. I think there's ways that we can streamline the process that doesn't make it as difficult.
And I might just add that, for political activity, there are all sorts of levels. From, if you have kids in school, join the PTA. As Julian mentioned, whether it's right or not, people tend to listen and give more respect to physicians. And what you have to say carries more weight because of that. So if you make those comments at the PTA, if you take time in the evening to attend a city council session and sign up to testify, if you join campaigns as a phone caller or knocking on doors, if none of you have done door knocking, I would highly recommend that activity. It is eye-opening to walk out into not your neighborhood, but other parts of your community and knock on doors and see who answers the door, what sort of conversations you engage in. And you will find that you can deliver a very effective message, and you don't get behind on charting because you're taking the time to do it. But I think the bottom line answer in this is it takes, as Edwin noted, unpaid time to do this sort of work. But it's the only way we're going to change the system is this sort of political action.
Yeah, and I want to be clear. There may be some folks saying, Edwin, are you saying we need to get politically involved? Like, I thought we're not talking about politics. When we say politics, we're saying that you are civically engaged in the process of making a better democracy. And that could be door knocking for the US Census and meeting your neighbor. I want to echo Russell. I've done a ton of door knocking. And when you think you know the community, until the community invites you in their home and they say, okay, I'm happy to answer your questions, but I have 3 kids that are sleeping. I need to take care of this. Can you hold on? And the beauty of sitting there and saying, wow, I did not know that someone who lives 3 blocks away from me is living a completely different experience than I am. And it helps inform the way we care for folks. I know it does for me. So yeah, so I appreciate that, Russell. That's such a good point.
Thanks, Edwin. So we have another question here from Gerald to you and Julian. As we recognize the end of slavery with the Juneteenth celebration, are we overlooking a modern slavery with the growing human trafficking problems that we have in the United States and other countries today?
I'm gonna let Edwin take that one.
I did offer to him first, Julian.
Yeah, it's a great question, because we don't want to overlook this process of justice, I'll call it, is that if we don't celebrate communities, then what happens is our communities get burnt out because it's just a constant struggle. And Juneteenth really represents an opportunity to highlight a moment that was a holiday created by Black folks who said we can finally celebrate something in this country. Even as early as the 1800s, they said we're going to celebrate that we got our freedom. But I don't think it should let us be blinded to the realities of what is occurring in human trafficking. And I'll also argue that we actually currently have 2 million slaves in our country that we don't talk about. And what I mean by 2 million slaves is the 13th Amendment supposedly abolished slavery, but for those who have read it, it says slavery shall be abolished except, so there's a caveat, and the caveat is except if you are duly convicted of a crime. Well, as a lawyer, to be duly convicted of a crime has proven to be highly subjective and highly racialized. Most folks in jail for non-violent offenses are Black and brown folks. But the 13th Amendment says if you are convicted of a crime, you become property of the state. You are a slave. And they've exploited that. So many federal prisons and state prisons use prison labor on behalf of private corporations to manufacture, build, even sit as phone call answerers for when you call customer service. And they get paid between 4 cents to 40 cents a day. That's happening right now by Fortune 500 companies. I mean, we had to push UW. UW was using prison labor. Now, granted, it's never like the organization going into the prison and saying, hey, we want to recruit some prison labor. It's usually a third party that's a employer who is using this, but it means that our organizations don't have the foresight to even contemplate that that could be a possibility. So yeah, thank you for that question. You're right. We shouldn't be lost or blinded to the realities of what continue to exist. And I think healing comes from celebration as well.
Thank you. Edwin and Julian, this kind of was touched on in the chat section, but I just didn't want to overlook. Esther Johnston had a question basically highlighting that in a lot of physicians' offices, administration prioritize the number of patients that you're seeing and basically are trying to have physicians churn out patients as quickly as possible, which doesn't leave much time for other types of community work. And she had asked whether there are any community physicians on this, chat here who can share successful strategies and approaches that they have taken with leadership in their institutions to help protect time and clinic funding to do this work.
I'm gonna let other people talk, but while you do that, I'm gonna share my screen with that graph.
You know, I'm just a resident here, but can you guys hear me?
Yeah.
We do have a free healthcare clinic called Grace Clinic in the Tri-Cities. I did a rotation there as part of the residency, but a lot of the community physicians will work there because they're open on Saturday mornings too. So that allows them to do their so-called 9 to 5 ambulatory family practice job with one of the large hospital organizations, but still make a difference in the community. If I wasn't leaving the area, I probably would have taken that up myself too.
Thanks, Cal.
So Esther, in answer to your question, I think as I noted a little bit before, a piece is you have to decide it's how you're going to spend part of your time that you do have, that we as physicians have, I think, far more than 80-hour weeks. We have lots of work, yet you can do things to build in bits of these activities. So I would highly encourage the things that come through, the speak out options for the AAFP, and very, very similar things for other organizations where it takes a click. When I was working on a community fluoridation campaign, I took my children out doorbelling with me because I couldn't leave them at home by themselves. And again, talking about knocking on doors, it's a real different experience when you knock on a door with a small child in tow. It's a bearded white guy than when you come and just knock on someone's door. So there are ways to build in little bits, and the other piece is there are different phases of our lives, and there are times when one can put in more time than other times, and all these issues we're talking about, alas, are going to be long term. It's going to be a long road of work, and so if you can't do a lot right now, that doesn't mean you won't be able to do a lot later in your career.
You're saying it was more efficacious with your kids?
I would say it's different.
Julian, did you want to mention anything about your slide that you had just thrown up there?
Just that, again, that linear relationship of the difference between the rich and the poor in any given population. And this is, based on countries. If you take a look at that left-hand side, and I can share it again. If you take a look at the left-hand side of that slide, then you'll see that trust is part of, right here. Trust is a part of that calculation that Wilkinson and Pickett made. And that's just incredibly linear, going from Japan, who has the highest smoking rate in the world, and they have the lowest level of income inequality and the lowest level of index of health and social problems, now towards the other end with the highest level of income inequality at the United States of America, and we actually have also the worst index of health and social problems. Then this is one explanation for why we're doing so poorly. We're 1 in 20 people in the world. We're 1 in 7 to 1 in 6 of the infections. We have arguably the best public health system in the world the last 100 years running. You guys, we are really, really hurting right now. And if you take it and just say why, you go all the way back and you'll find that desire for control and wealth and power, same thing that Martin Luther talked about, the triple threat of racism, militarism. These are the fundamental flaws of our democracy. And I go back to the Constitution a lot. I go back to the Declaration of Independence a lot. And I think about we the people of the United States of America in order to form a more perfect union. So we know we're not perfect, but we got a long way to go. But we can keep working on this. But we have to go back to basics. And looking at that gap between the rich and the poor, and all the, every time we have essentially the conservative majority in power in this country, what do? They cut the taxes to the rich. It's not the same as when, in old England, they used to tax the poor. No, they don't tax the poor anymore. They cut taxes for everybody. It's just that the rich have way more tax cuts. And what is the end result? It's the same. A few people got a lot more, and most people have very little. And that disparity in wealth and power is what drives a lot of this.
A lot to think about. I think on that note, we are at time. I want to again thank Dr. Julian Perez and Edwin Lindo for being here, for sharing all your insights, and for giving us a lot to think about and a lot to work on and plan for. I hope you guys enjoyed the session. Again, I wanted to remind you that we will be having a town hall for the WAFP very shortly to talk about anti-racism efforts. And also wanted to let you know that we are hosting another virtual CME at no charge. That's going to be Saturday, July 25th, most likely in the morning. So save the date for that one. And also let you know that the AAFP is hosting a virtual town hall of their own this Monday. And that is at 5 p.m. Pacific time on the association between racism and health outcomes. So I'm sure that will be very interesting as well. Russell, Julian, Edwin, any last minute comments from you folks?
Just that, you know, one public health lesson we know is that you keep plugging the same message over and over and over, pretty soon it sticks. And so what I tell them on the radio just before we end is, together we'll beat this. Juntos venceremos.
Agreed. No, just thank you for having us. And it's the beginning, the work continues. I think we're at the inflection point where with all of your support, we can make transformational change.
Yes. Juntos venceremos. Was that
Yes,
it?
Together.
Juntos venceremos. Together we will beat them. Together we'll be
Juntos
victorious.
Yes.
Juntos venceremos. All right. Everyone, have a great weekend. Thank you for being here. Juntos venceremos.
Yes.